Well, good afternoon, everyone, and I want to thank you for joining today's webinar, 2024 CMS Updates, the critical role of acute kidney injury in hospital quality reporting. I would like to take a moment to thank Accuryn Medical for sponsoring this webinar. My name is Stacy Ramsey, and I'd like to share a few logistics before we begin. Participants are placed on mute throughout the meeting. Please submit your questions or comments using the Q&A box on the control panel on your screen. Questions will be answered throughout the presentation, and while we try to answer all questions, please know that the webinar will last no more than an hour. This session is being recorded, and the recording will be made available to all members who registered for this webinar, along with the PowerPoint presentation. On behalf of NACNS, I am pleased to introduce today's moderator, Alice Benjamin, Nurse Practitioner, Emergency Medicine. Alice is a highly experienced family nurse practitioner and clinical nurse specialist, specializing in cardiovascular health, critical care, and emergency medicine. Alice has led hospital clinical training programs aimed at improving patient outcomes with a focus on acute care and early detection of critical conditions. Her expertise has contributed to the development of many quality improvement initiatives that align with national healthcare standards, including CMS reporting requirements. Beyond her clinical work, Alice is a recognized healthcare advocate and thought leader, having served as a spokesperson for the American Heart Association and AARP. She is the founder of AskNurseAlice.com and hosts the popular Ask Nurse Alice podcast, providing healthcare insights to professionals and the public alike. Her clinical experience and involvement in educational programs position her as a knowledgeable voice in discussions on CMS updates and the role of AKI in hospital quality reporting. Now, Alice, I'll turn it over to you.
Thank you very much. Welcome, everyone. I'm so excited for today's presentation. Thank you to NACNS for hosting this. Again, thank you to Accuryn for sponsoring. And to start our conversation today, we'll be focusing on the critical role of acute kidney injury in hospital quality reporting, which is a topic that has become increasingly important with the upcoming changes to CMS's inpatient quality reporting and inpatient prospective payment system programs. Now, I know that sounds like a mouthful and may be newer information for some of us joining today, but as many of us know, hospitals are now required to report electronic clinical quality measures, and AKI is becoming a key metric in these reports. These changes aren't just about compliance, they're about direct impact to the patient outcomes and quality of care delivered, such as early detection of AKI, which can significantly reduce mortality rates and improve recovery. So today's discussion, our guest speaker here will give us a valuable insight into why AKI is so pivotal, and how multidisciplinary teams can improve readiness to address it, and what steps frontline staff and healthcare providers can take to ensure early detection and intervention. Our speaker, Thomas Calabro, brings a wealth of experience in critical care, nursing leadership, making him the ideal person to guide us through these complex updates and help us understand how to implement them effectively in our practice. Tom has nearly 25 years of nursing experience. He's had a dedicated career to critical care, nursing leadership, making a mark in both academic, level 1 trauma centers, and community hospitals alike. His clinical expertise spans pediatric to adult critical care, emergency medicine, adult cardiothoracic critical care, and pre-licensure nursing education. Tom has also taken on numerous leadership roles, including Director of Critical Care, Assistant Vice President for the Cardiac Service Lines, Surgical Trauma Service Lines, and most currently the Senior Director of Surgery and Musculoskeletal Service Lines. And in 2014, he was awarded the Georgia March of Dimes Critical Care Nurse of the Year. Now, what set Tom's apart beyond his impressive credentials is his hands-on approach in leadership. Colleagues often joke that you'll never find Tom in the office, but Tom will proudly admit that's because nurses are in the units, not in the office. He believes in leading from the front lines, working along nurses in the environment to better serve them and the patients they care for. Please welcome our speaker, Thomas Calabro.
Wow, Alice, that was awesome. That was great. I was like, boy, I'd like to meet this guy. That was pretty good. Thank you so much for that wonderful introduction. I'm happy to be with everyone, and we have a lot to cover today. And this is a great topic. I think it's very timely because there are a lot of changes coming about. And so as we start to think about our quality measures, I know that a lot of institutions are starting to look at what are we going to do for quality next year? What are we doing for quality in this coming fiscal year? This is a timely topic because it's going to cover a whole bunch of areas that we need to be aware of as leaders, as clinicians. And so today we're going to kind of jump in there, kind of give you a little bit of a framework for understanding all the intricacies of this. And so we're going to explore this. And as we go through it, if you have a question, please let us know. So our learning objectives for today. At the conclusion of this discussion, you'll have a better understanding of the Centers for Medicare and Medicaid Services, the reporting systems, and how we're paid, the prospective payment programs, a little bit of the changes coming up to the eCQMS, the electronic computerized quality measures for acute kidney injury, and some of the others that are coming. And then how do we develop a multidisciplinary approach for all of this? And how do we start to really drive the needle on some quality measures across the board? So as we think about this, one of the things that is always a challenge, like so many things in healthcare, if we can't come up with a code word that conveys a message to our colleagues, we develop abbreviations that we struggle to remember their exact meaning, like SIADH, syndrome of inappropriate antidiuretic hormone. Yeah, people know what it is, but sometimes it takes a minute. Kind of, oh yeah, that's right. Not a lot of P, too much P, that kind of thing. Then we go and we take a complex industry like healthcare, and we combine it with the global leader of acronyms and abbreviations and things that don't seem to make sense, the federal government. And now life really gets interesting, like HIPAA, the Health Insurance Portability and Accountability Act. Now, we all know what it is, and we abbreviated HIPAA, but how often do you see it written incorrectly as HIPPA? Just one of those things that, oh, you have all these acronyms and all these abbreviations. We just don't really understand necessarily what they are. Today, we're going to delve into that a little bit. And so we're going to start to look at things like value-based purchasing, VBP, inpatient prospective payment system, the quality reporting system, and the electronic computerized measures. You know, we're clinicians, and we have our own vocabulary, our own frame of reference for what we do and how we do it, and how we see the world, right? As leaders and as a CNS, we're expected to understand and operate in a foreign land that has its own vocabulary, that of the federal government now. And we understand our acronyms and our abbreviations because they apply to what we do every single day. But now we start to have to look at it in a different way because the meanings, they're important, but we don't necessarily know the language that is being used. And why is it important? It's because our frontline colleagues are depending on us to be their translators. And secondly, it's how we get paid, how the government pays us in hospital settings for the work that we do, that great care that you guys provide every single day at the bedside. And so as the leaders, as the CNSs, our job is to decipher the language, decipher the information, and present it to our teammates in a way that they can understand it and they can act on it and they can provide great care. And so in a sense, it's alphabet soup. So some of the alphabet soup, again, we'll discuss will be that value-based purchasing program, the inpatient prospective payment system, the inpatient quality reporting, and the electronic computerized quality measures. A lot of numbers in there, a lot of initials, a lot of different words, but it's going to be important for us to have a frame of reference as we go forward. So to understand the inpatient quality reporting and inpatient prospective payment systems, we got to start with our basic understanding, and that is value-based purchasing. So back in 2008, CMS started working on the idea of a value-based purchasing model. And it's an incentive program designed by CMS and to drive quality in hospitals. Value-based purchasing encourages outstanding healthcare delivery by rewarding quality, not just quantity, but great quality outcomes. If we're giving great quality care, then we're going to be paid in a better way. So essentially what CMS has done is create a model where the hospitals are reimbursed for care under a broad set of performance payment strategies that link the financial incentives to performance-based incentives through a predefined set of measures. Now, prior to value-based purchasing, providers and hospitals were paid on a fee-for-service type of model, where insurance companies paid providers based on the volume of their services that they provided. Under this model, essentially, there's no drive, there's no incentive for quality outcomes. Now, let me give you an example. So let's consider a fella, JB, and he's a 57-year-old male, and he comes into his primary care provider with complaints of nondescript knee and leg pain. Now, his doctor examines him and orders an x-ray. Now, upon results of the read, he refers JB to orthopedics. After reviewing the films, ortho orders an MRI, and the results are reviewed again, and then they set him up for surgery. In the fee-for-service model, there's a fee paid for each of the providers, even if he doesn't get relief from the pain. Even if the outcome is not great, everybody still gets paid. But in value-based purchasing, the doctors and hospital providing care would receive insurance reimbursement for more than just a number of those services. The reimbursement would also take into account the outcome of the surgery, whether it would factor in how the quality of that surgery was delivered, the patient experience, and then was it a cost-effective type of procedure that was done. Now, the great thing about the value-based purchasing is that it attempts to reduce inappropriate care while rewarding the best performing models of care and those providers who have great outcomes. And in this model, CMS and private insurance providers reimburse healthcare providers based on those successful outcomes. Now, the IQR is the Hospital Inpatient Quality Reporting Program. It's a pay-for-reporting program for acute care hospitals. So under this program, certain types of acute care hospitals submit data to CMS on quality measures every single year. Again, the goal of CMS is not to be someone to look over your shoulder, but basically is to help drive healthcare for all of us to push quality to the limits. Now, the hospitals who participate have their data publicly shared by CMS, and that's available to anybody on the Care Compare website. Now, the beauty of this is that we, the consumers of healthcare, can make informed decisions. This is why it's important for us. And aside from the obvious, it's also important for other reasons. If you think about it, in healthcare, we sell a product that no one can afford, no one wants to buy, and many don't want it until they have to have it, and they can't afford it. So that's one of the reasons that patient satisfaction scores, quality outcomes are so important. If we can make a positive experience out of what is often a lifetime changing event, then we've done our job. And so the idea is if we can push quality further and further, then our outcomes will be better and the community is healthier. In most cases, acute care hospitals are paid under the inpatient prospective payment system. currently in the United States, more than 3/4 of acute care hospitals are reimbursed under the inpatient prospective payment system. Now, the IPPS pays hospitals a flat rate based on the average costs across all hospitals for a specific diagnosis. Now, regardless of whether the cost to care for that patient was more or if it was less, under this model, CMS uses DRGs, diagnostic related groups, to determine what the reimbursement is going to be. Now, payment is also adjusted for differences in area wage costs, and depending on the hospital and the case, teaching status, high percentage of low-income patients, the use of new technology, extremely costly cases, things like that. There are some variations, but for the most part, everyone's paid at the same level. Now, these hospitals and these providers must meet specific quality metrics to receive that reimbursement. Now, CMS can reduce the payments based on patient outcomes, and if that occurs, then they can actually be excluded from participation in value-based purchasing, which could actually hurt them in the long run. So it's a complex system, but it really works well for our patients. Now, the thing is, you'll notice that I didn't say that they pay them for it. We talk about reimbursement. They're reimbursed for the care because it occurs up front.
This is Alice.
Yeah.
Just curious, as the clinical nurse specialist, we're tasked with doing a lot around improving quality outcomes, patient experience, helping to meet certain metrics. Not all the time do we have access to these reports, or is this terminology commonly used, unless and I'm speaking for myself, going to like a leadership meeting, which really we know we're going to be talking about money. How can I, as a CNS, become more familiar with these reports? How should I be incorporating this in my day-to-day activity to make sure that I'm meeting not only the metrics and outcomes for patients, but also aware of these financial implications in the background?
Yeah, that's a great question, Alice. So the way that we can do it is, as the people who are right there on the front line, the CNS who is working with the teams, is to meet with the quality department, get that information from them. This is what they do every day, and every hospital has some form of a quality department. This information is readily available to you to let you know how are we doing. And we track so many different things. People use different models to get their information regarding patient satisfaction, Press Ganey, and there are other different companies out there that collect that same data. We also can contact our teams to find out how are we doing comparatively across different hospitals. There are ways we can go out and we can compare that. The Nursing Data Quality Index, those and the NQI, that's another place where we can figure out how are we doing with some of these initiatives. So these things are readily available to nurses in most leadership positions and in all hospitals. And I would suggest contact your nurse manager, contact your director, or anyone in the quality department, and they can get you that information. So the inpatient prospective payment system is a little bit different than, well, as we said, the fee for service. So let's use this clinical scenario to kind of give us an idea. So MC is an 83-year-old male who's in relatively good health. He lives alone, he's independent, and his medical history is remarkable for hypertension, type 2 diabetes that's controlled with diet, and glaucoma. Now, he noticed that there was a floodlight on the side of his garage that needed to be replaced. So he got the ladder, proceeded to climb up to change the light bulb, and about 8 feet off the ground, he lost his balance and fell onto the ground on his left side. Now, his neighbor, who was in the adjoining backyard, saw what happened, and so he went to his assistance and he activated 911. And MC was transported to the local emergency department. Upon arrival, Nurse Alice was there, I'm sure, and she took great care of him. And in the emergency department, because of his age, they activated the geriatric trauma protocol. They performed some pan scans on the gentleman. They also, because he was trauma, they placed a Foley catheter and admitted him for rib and hip fractures. So He's admitted to the trauma service. He's taken to the OR by the orthopedic team for repair of his hip. And postoperatively, he's admitted to the ICU as a precaution due to his age. Now, postoperatively, he's doing fine. And on hospital day 2, he's transferred to the hospital service and moved to a step-down unit. Now, in this scenario, assuming there are no other concerns whatsoever for this patient, he is going to be paid, or the hospital will be paid, based on the DRG for the hip fracture and repair. Now, if the care that MC requires is more complex than a basic repair, it's important that this be communicated to CMS because it will change the reimbursement. How do we do that? Well, we do that through documentation. This is one reason why documentation is vitally important when we're providing care. Now, I know from a nursing perspective, it's very difficult. It's extremely time consuming to move through the EMR. And we'll talk more about that in detail more later, but the more detail that we can provide, the better. Now, while non-clinical information such as population health, public health information, other quality metrics may not seem important and just another box to check, they are part of the updates to the inpatient quality reporting system and the eCQMS. So it's very important that we get all this data so that you can get credit for the amazing care that you're delivering every single day. So he comes into the ED through the ambulance, he gets admitted to the hospital, and then they prepare a bill based on that hospital diagnosis. And then once he's discharged, and he continues on that continuum of care. That's the hospital billing then takes place, but that reimbursement takes place for the hospital early on. Over the last few years, there have been some updates to the inpatient quality reporting system. And each year, the number of required eCQMS, electronic computerized quality measures, increase. Now, the eCQMS are derived from the patient's health records where the data is electronically extracted to measure the quality of care provided. Healthcare organizations are required to electronically report the eCQMS, which cover a wide range of patient care and quality related topics: patient and family engagement, patient safety, care coordination, population health, public health information, efficient use of healthcare resources, and clinical processes, clinical effectiveness. All of these things are important information that are collected through the eCQMS. Now, the period for collecting data or reporting it, it varies. There are various quality programs that have different requirements for reporting. So organizations have to follow the respective guidelines for those reports. And it's a little bit different. It can be kind of confusing. This is why we have a quality department, right? So recognizing that medical care and the resulting quality are ever evolving constructs, CMS has made annual updates to ensure that the eCQMS reflect actual changes in what we do, so that they're working on the most evidence-based information. So they look at evidence-based medicine, they look at code sets, talk more about that in a second, and they measure the measure logic, the logic that goes into the measure that they're looking at. So if it was about, for example, patient and family engagement, that type of thing. So important to the development of those eCQMS are the value sets. So if you think of these value sets or these code sets, they're code words, they're keywords. Think of it as data that our clinical teams enter into the EMR. This is why the documentation is so important. It's about taking credit for the great care you're giving, and no one sees in that moment what you're doing, but they see that that great quality care took place because it's in the historical record. And when it's reviewed, other nurses, other providers will look at it and say, that patient got great care, or that patient didn't get great care. Because the only thing we have to judge it on, CMS has to judge it on, is what's in the record. So the words come from standard clinical vocabularies that provide effective diagnosis and support intraoperative health information exchange. We all want to be using the same language, and so that information flows freely. That's why they come up with these code sets.
I have a question.
Yeah. Yeah.
So you're obviously data drives all of this. Everyone's looking at the data,
Yeah.
influences so many things. Just curious, are there gaps in how we collect the data? Meaning, for example, we have EMRs, where usually we're either picking a drop down, we're putting in a value, or there's narrative notes. Is there a standardized way of how we should collect this data so it gets to CMS and all the people that need it for the IQR programs, so they have the data, the correct, clean data?
Yeah, the correct. So a lot of this is extracted through different ways. So we have data extractors, and if you look at and it doesn't matter really which EMR you use, the EMR folks who design these programs have all of this information, and they work to ensure that the people who buy their programs actually are able to complete the data and get the most credit as possible. And that's why it's very, very important that we always make sure that we're updating those. We get these notices in the hospital frequently and says, oh, we're going to update the EMR tonight. And everyone kind of rolls their eyes. Oh, gosh, not again. And we'll have an hour downtime or 2 hours. And part of that is so that these types of things can be updated so that we can get that information. So the best thing that we can do is, if there's something that your leadership has asked you to document, there's usually a great reason for that. And it's because it's related to these types of things so that we can get the most information, get quality information for the work that you folks are doing every single day. Remember, this is a quality program, so it never ends. And we're getting good at quality, but we're not perfect. And until the day comes, we're going to continue to have more and more eCQMs. It's not a punishment, but it's a way for CMS to reimburse for the care provided.
Great point. And so just a side note for my CNS peers, because sometimes I feel this frustration. Our nurses are doing great care. We're doing it. It's just not getting captured. Yes. So it sounds like if we feel like our numbers aren't where we're supposed to be, probably a good idea, connect with quality, connect with your EHR folks, and make sure that everyone's on the same page about what needs to be documented and where, so we can get credit for the great care that our nurses are providing.
Yeah, and now that's a great point. And the one other piece of that is, and all the CNSs I've had the privilege to work with over the years, one of the things that they're extremely good at, and I would encourage people, if they're not doing it, to do it, go to the GIMBA, go out to the floor, go to the unit, sit down with the nurses and say, hey, I noticed we're not recording this data. What's the obstacle? Because if we know what the obstacle is, as leaders, as CNSs, we can fix it. That's the beauty of this. That's the great thing about being in both worlds. As a leader and being on the front line, you have that trust, you have that clinical knowledge, and you are able to drive change. So some of the things that are coming up that we have to be aware of, and there's a few. So the eCQMs are done in this way. So you have a reporting period, and that starts in a particular year, and all the years are changing. And then there'll be the time when the reimbursement, the payment is determined, or the penalty. And so what happens is there's a span where data is collected, usually for 4 quarters, sometimes more, but for 4 quarters, information is collected. And then from there, there's a synthesis of the data, and then we look at it and see what do we need to be aware of. So coming up for eCQMs, coming up, there'll be 3 facility selected eCQMs. So you can pick whichever ones that they want, and there's a large list. But the ones that are coming up for this next year are the safe use of opioids. We've heard a lot about the safe use of opioids, and particularly concurrent prescribing is a concern. Concurrent prescription of opioids and benzodiazepines puts the patient at greater risk of unintentional overdose due to the risk of respiratory depression, or even people with who will abuse it. So, basically studies have seen that between 5 and 15% of patients receive concurrent opioid prescriptions. And what we know is that people who have multiple prescriptions like this have a rate of fatal overdose that's 10 times higher than in patients who are co-dispensed opioid analgesics, one just alone. So that That's a big thing. So we want to make sure that we're really prescribing appropriately. For cesarean births, the measures the rate of nulliparous women with a full-term single baby in a vertex position who have been delivered by C-section. Now, this is an inverse measure, so the lower the rate, the better. CMS started to look at this and said that an acceptable rate for this is 30% or lower. Now, CMS is also quick to caution everyone to say, just because you don't want to push it down artificially, that could be unsafe. Seriously consider what is happening with your patient population, because different populations have different needs, as we know. And then severe obstetric complications. One of the things that we know, unfortunately, is that the United States experiences higher rates of maternal morbidity and mortality than most other developed countries. These rates continue to trend upward over the last few years. And so if we can figure out how to get that down, it's going to be better for our nation. It's going to be better for the world. Research indicates that the overall rate of severe maternal morbidity increased almost 200% between 1993 and 2014 to approximately 144 per 10,000 deliveries hospitalizations. So significant concern, particularly in our populations who experience poverty, and also patients who have not received prenatal care. Now, in 26, we're going to start to collect information on hyperglycemia. That is hospital harm hyperglycemia. This measure is going to look at the number of patients in hospital days who have an elevated blood glucose. Now, why do we know that is important? We know that that has been tied directly to adverse outcomes, increased length of stay, as well as infection rates. And so what the CMS is asking us to do is to use evidence-based standardized protocols and insulin management programs to decrease hyperglycemia and improve glycemic control and safety. That also will have implications on the outpatient side down the road as we refer patients back to their primary care post-hospitalization. Equally of concern is hypoglycemia. This measure is going to focus on hypoglycemia as an outcome in the inpatient setting. Essentially, we know that hypoglycemia is a common event in the hospital setting. And in two studies, they found that there are over 800,000 adverse drug events in the United States. That doesn't seem like a whole lot, but it really is. And that is a concern. And there's a way for us to get control of that. And then opioid adverse related events. Again, this is one of those measures that's extremely important. Opioid-based analgesia is common treatment in our postoperative pain management for patients, particularly in surgical patients. I know in our area, working with MSK, musculoskeletal, and working in general surgery, there are a lot of patients who have received historically opioids. We're looking to figure out ways, evidence-based ways, to drive down the use of opioids because we know that it's been noted to increase longer length of stay by about 55%. If we can decrease the length of stay, then again, this is where patients tend to do better, but also the reimbursement will be better for the organization. Pressure injuries. Gosh, pressure injuries, it's like the plague that never goes away, isn't it? Pressure injuries are the things that it's the bane of our existence as leaders. It's the bane of our existence as nurses, as CNSs. It's one of those things that it seems like no matter how hard we try, it just seems to never go away. The incidence of pressure injuries in hospitalized patients has been estimated to be 5.4 per 10,000 patient days. That's insanely high. The rate of hospital-acquired pressure injuries is about 8.4% of all patients who are admitted to the hospital. Now, most of these pressure injuries, over 50% of these, were preventable. And these are typically what we're looking at is stage 2 and higher. So what the leaders are asked to look at is to figure out how do you change that. We know that things like nurse staffing, that we measure in hours per patient day, skill mix, expertise. All of these things come into play to decrease the incidence of pressure injury. What we're being asked to do as leaders from CMS is to figure out, how do we do this differently? How do we do a better job with this? And then finally, the last one that is that we're going to talk about in detail is acute kidney injury. Now, this measure is going to focus on stage 2 or greater acute kidney injury. It's an outcome that the hospital, for the inpatient setting. Now, the incidence of AKI in patients and just general patients coming in the door is between 10 and 20%. And among critically ill patients, the incidence of AKI has been reported as high as 45 to 50%. Now, we know in cardiac surgery patients, it ranges from 30 to 50%. Less severe kidney injury and acute kidney injury requiring dialysis, they're going to affect approximately 2,000 to 3,000 people in the population, which is a lot of folks who are going to be placed on dialysis potentially that we could have avoided. Acute kidney injury, AKI, can be reversed if it's caught early. Now, it's not always avoidable, but the CMS recognizes that there are opportunities for us to do better than what we are doing. So some of the other ones, real quickly, will be postoperative respiratory failure. And this measure will assess the number of elective inpatient hospitalizations with postoperative respiratory failure within the first 30 days. OB patients will be excluded from that measure, and then falls with injury in the hospital. And then we know that that's something that is a concern for all of us, and we've been working on that, I know, for quite some time. So why AKI? Why now? Well, AKI is a significant concern, as we mentioned moments ago, in the acute care setting, with the incidence in general hospitalized patients of 10 to 20%, and then in the critically ill, about 45 to 50%, and then with cardiac surgery, and 30 to 50%. So there's a large population that's going to be adversely affected by this. And we saw a lot of AKI develop during COVID as well. So who's at risk? Well, to understand who's at risk a little bit better, let's look at our scenario. Remember MC who fell off the ladder, right? So again, MC is an 83-year-old male who is in relatively good health. He lives alone. He's independent. His medical history is remarkable for hypertension and type 2 diabetes and glaucoma. He's typically non-compliant with his blood pressure medication. And upon admission to the ED, he had a blood pressure of 180/90. His weight is 125 kilos. Now, the team attributed his pain and anxiety to driving his blood pressure. And then with morphine, his pressure decreased to 160/84. And then when he was transferred to the OR, he underwent general anesthesia for repair of his hip fracture. Now, upon induction, his pressure dropped again, and he was maintained with a MAP ranging between a low of 55 for about 20 minutes. And then for the balance of the procedure, which was 3 hours, his overall MAP range was about 62. Now, upon admission to the unit, his blood pressure was 174/80, heart rate of 82, and respirations were 16. Now, the resident wrote for him to receive antihypertensives with a goal of a systolic of 130. So you can see that he's being managed, and the goal of 130 seems like it might be a good goal. Now, at the end of hospital day 1, his urine output was 1,300 mLs. So we'll remember that. So who's at risk for this? Your age is going to increase this over time. As we get older, you're at more risk for AKI because renal perfusion, renal function decreases. People living with hypertension, certainly, as we saw here with MC, and then people who have a history of DVT or clots, patients with liver disease and kidney disease, these are the folks who are greatest at risk. So the common causes of AKI are medications, organ failure, hypovolemia, iatrogenic causes, which we'll touch upon in a minute, infection, sepsis, and then shock. So remember now, he's admitted to the unit, and his blood pressure is high. He has a history of hypertension. The resident writes for a systolic goal of 130. Now, when he gets out to the step-down unit, his blood pressure was 130/78, his heart rate 74, respirations of 14. In fact, here's what also happened that day. The nurse got tied up with a patient for 4 hours, and MC had a Foley in place. So while she was out taking care of that patient, the urimeter collected 600 mLs of urine. Came back and she wasn't sure what to do with that. So what do we do with that? And so what she did was she documented the output as 150, 150, 150, 150. And so to get to 600. Now, she's not trying to do anything wrong. She's trying to fill in the boxes. But what we know about AKI is that one of the early signs is a change in renal function and urine output before we start to see necessarily changes in blood work. And at the conclusion of hospital day 1, his urine output was 1,300 mLs. At the end of hospital day 2, it was 1,200 mLs. Now, remember, for his weight, he should have a certain goal of urine output. Now, you ask people, and you're going to get different answers, right? What's normal urine output? People will say, well, it should be 30 mLs an hour. That's an old answer. That's an incorrect answer. Our goal should be 0.5 mLs per kilo per hour. So someone who is in his weight category, our goal should be 62.5 mLs per hour, or for our goal of 1,500 over 24 hours. Now, it's not until the next day that the team recognizes that there's a concern, because somebody starts to add up the I's and the O's, and that's why documentation and communication are so important on the unit. So what could have happened here? Well, there were a few things that kind of had some influence here. One was that he was given antihypertensives, which dropped his blood pressure from where he's been living at 170. And now we've created a relative hypotension. And then now also with that, he had induction of anesthesia where he had a prolonged period of a lower MAP, and that was not perfusing his kidneys. And so that kind of kicked him into that AKI scenario. So AKI then is harmful, potentially treatable, but even a minor reduction in kidney function can have an adverse prognosis for our patients. So early detection and treatment of AKI is one of those things that's going to improve outcomes. So AKI is defined as any of the following. It's going to be an increase in serum creatinine by 0.3 milligrams per deciliter within 48 hours within admission. Increase in serum creatinine 1.5 times the baseline, which is known to be presumed to occur within the last 7 days. And so the one that we're going to be looking at for our patients is stage 2 or greater. That's what CMS is going to be asking. So for stage 2 or greater, then serum creatinine of 2 to 2.9 times their baseline, and then urine output of less than 0.5 mLs per kilo for greater than 12 hours, greater than or equal to 12 hours. That's where we got ourselves into trouble with this gentleman, because he had it for much more than 12 hours. So acute onset then is often reversible if it's caught early. And so we want to look at glomerular filtration rate, the prevalence of AKI, as I said, 10 to 20%, up to 45%. And from a financial burden standpoint, $5.4 to $24 billion a year for this. The mortality associated with AKI is almost 24% in adults. And the thing that's important, again, is following that initial insult, the BUN creatinine may remain within the reference range. And it's not until later on that we start to see a bump in those indices. And that's where that urine collection and having that available right away is important. So why, yeah.
If I can just say, as many of the folks on here are CNSs, and we're responsible for the onboarding, training, ongoing education of many of the nurses. And in nurse language, we're familiar with pre-renal, intra-renal, post-renal.
Yeah.
And you've mentioned AKI, the different stages. I don't know, quite honestly, if that's common language amongst nurses these days. And I'm talking about the bedside nurses.
Yeah.
When we get to stages, we're thinking of end-stage renal disease, then,
Right.
you know, so, and I'm just going to ask, the silly question is the one not asked. And even though I'm an APRN, I want to just clarify. When we talk about end-stage renal disease in those stages, that is very different and separate from AKI in those stages, correct?
Correct. So if we think about that,
yes.
yeah.
Okay.
Yeah, you're absolutely right.
Right. Oh, no, go ahead, please. I just wanted to clarify that, because sometimes, you know, sometimes you have that thought, you're like, I should know this. I don't really want to ask it, but let me just ask it. So that was one of those moments I just had.
That's a great question. Yeah, and so so all that blood pressure and that management of those patients, those would fall into that pre-renal type of a stage where we can control that. That intra-renal piece, we would maybe look for an obstruction, right? Those types of things. So this is where we at the bedside can help with that care. And so why is this important for us as a CNS? Because Alice, you said it so well. We are responsible as leaders and as CNSs for onboarding these patients. And so one of the things that we've got to do is we've got to start now. We've got to start to drive change. And how do we do that? Well, the first thing is this is a systemic situation, and it's not going to change overnight. It's not going to be solved overnight. And so it's going to require you as the CNS to pull together multidisciplinary teams, multi-professional teams, and discern a standard of care that may not have been addressed previously. It's going to require people who typically don't work together to work together. One of the beauties of all of the CNSs I've ever worked with is that when we think about the org chart, there are white spaces in the org chart, and the CNS is an expert. They're a ninja at working in the white space, in the spaces between the org charts, between those lines, pulling those diverse teams together to talk about how do we start to treat this at the bedside, so the nurse at the bedside is not caught up in the middle. So it's a systemic issue. It's going to require a systemic approach. Now, what are potential areas for impact? Well, some of the potential areas for impact is how do we admit patients? Patients coming into the ED, they could already come in stage 2. What does that mean for us as far as these measures go? Or are they very close to becoming in stage 2? Where are they? How do we manage patients in the OR? What's our hypertension and hypotension management model going to look like? What's the role of the PCP, the primary care provider? And then how do we get the EMR at the office talking to the EMR at the hospital, even if they don't have interplay, they're not on the same model? How do we get that information? Because had we known that he was non-compliant, had we known that he had hypertension, maybe the management of this patient would have been different and he would not have slid into an acute kidney injury. And then how we manage patients in the acute care setting, that data collection is going to be very, very important. And then how we track our patients in that way. And so for the CNS, then the beauty of this is understanding clinically what has to happen. And he or she knows that information, what we need to do clinically. And now they're going to marry this up with what do the nurses need. And so when we think about that, then we have to come up with a few things. First thing is an agreed upon standard of care. Perhaps in our institution, for example, we went with a map of 65 or greater. That's kind of where we are, unless there's a contraindication. Avoid drops in systolic blood pressure to less than 40 millimeters of mercury. So if he's at 170, don't take him lower than 130. If we do that, then we're going to set him up for failure. We got that information working with our nephrologist. Now, the other part is we've got to have accurate data collection, and we've got to have predictive analytics working here with us. So the thing is, that nurse scenario that I provided for you earlier, where she got tied up in a room for 4 hours, that's not unusual. That's one of those things that happens. That's real life nursing. And so in response to that, we've got to have a way that we can get accurate hourly urine output so that we know what's actually going on with that patient. Because As that urine starts to dwindle off, that starts to become our indicator that, hey, we're getting into trouble. So something that could tell us and upload that information automatically to the EMR so that we could see it and we could discern it and say that looks like it's correct is extremely important. We already know that we have that as a challenge for us. The second piece is getting ahead of it. So an instrument or a system that could use predictive analytics to look at what's going on with the patient and predict this patient is being set up for acute kidney injury is vital. And so we know that that information and that technology exists currently with the Accuryn system. We want to decrease the margin of error. That decrease in margin of error, it takes place when we have to look sideways, climb down on. Now I'm getting old. I can't get down on the floor anymore and look and see if that urine output's right. The beauty of this type of a system is it provides that for you. And then we've got to think about the nursing care burden. And then how do we take that away from our nurses? Because providing care today is extremely hard. Yeah, the patients who are on the floor today, 10 years ago, were in the ICU. And we have got to get our minds wrapped around that. So, in summary, the inpatient quality measures, they are achievable. It's going to take a concerted effort, a strategic approach that's going to require multidisciplinary teams to come together. Over the next 3 years, there'll be 11 measures that will be introduced and addressed. Measures such as AKI require early process change discussions. It's going to take a while to get people to agree on what those parameters look like, how to build it in your EMR, how to look for it, and what does it need to look like for your particular organization. Frontline teammates are going to require the right knowledge, the right training, and the right equipment. And that is essential to be able to meet these measures. And then you as a CNS, you are integral to the change in the culture and the clinical environment. They watch you, they take their lead from you. I've seen it for decades. You are the most important person as a leader because you walk in both worlds, and we cannot do this without you. Alice, I'll turn it back to you.
Oh, wonderful. This was so much great information, Tom. And it actually, and I know we have about 10 minutes for questions. So again, please put your questions in the Q&A and we'll be sharing them here. Tom will answer them. Tom, we do have a couple questions here. So I'd like to go ahead and present those. The first one comes from Janice. She asks, will you be providing examples of specific data fields that must be reported by nursing regarding AKI in order to fulfill the requirements?
There's a lot of data fields that they're going to be looking at. So the data fields that they will be collecting will be looking at the serum creatinine over time. But for nursing specific ones, that's where your urine collection and your accuracy with that is going to be extremely important.
Okay. Wonderful. And there's a part 2 to that. Do you recommend using guidance of clinical excellence bundles to assist in developing orders and reporting documentation by providers and nursing?
So I think bundles are excellent. I think bundles are great, and they help to give us a framework. Where the challenge becomes with bundles is sometimes, in my experience, is that elements of the bundles fall out. And so if we're going to do the entire bundle, that's great. But if people pick and choose elements of the bundle, that's where the whole thing starts to fall apart. So I am in favor of bundles.
Okay, wonderful. Okay, good. And we have another question. It comes from Nikita, actually a request. If you could please repeat the costs associated with treating AKIs.
AKIs range up from 5 to over $20 billion, depending on the range that you're looking at, whether you're considering just the acute care or the ICU altogether.
Okay. Now, and I'm just going to insert a thought here. And this should not be, right? Sometimes we're so used to seeing abnormal that abnormal can sometimes become normal or relative to, right? How bad is something relative to what we've seen? But Tom, it seems like a lot of people in the hospital have AKI, a lot of people. And so if you could just kind of remind us, these are CMS guidelines, they're coming, they're changing. what is that start date? Do we have a start date or time frame as to when CMS is going to dig their heels into the ground and say, now, if we don't see improvement, this is where the financial impacts are going to happen? Do we have a date and time for that yet?
We do. So already AKI is one of those elements that already kind of exists as a quality measure, not in the same way as the eCQMS, but it's one of those things that they're already starting to look at. But as far as the data collection and then the reimbursement questions, it starts in 26. So they just recently changed the deadline on that. And so now they pushed it back. I suspect they pushed it back because so many have responded back and said, hey, this is a bigger problem than you may realize for us to operate within. And so they've stepped it back a little bit. So 26 and 28 is when we'll start to see the real impact.
Okay. So this is really kind of the time to get ready. The race is getting ready to officially start, but we should definitely be in our warm-ups and stretching and get things teed up for all of this, correct?
Correct. I think it's a great analogy, a sports analogy. So here's what we need to do. We need to pick our team, number one. Who's on the team? Who's not on the team? And you know how hard it is to recruit people to be on teams, particularly with something that is as big as this. When we posed it here at our institution, I said, we got to start to look at this, because at the time, we thought this was going to roll out in October for AKI. And so we started working on it last year. And so when I started to pull people together and I said, we need to talk about AKI, and the response I got was, oh, do you realize how big that's going to be? That's huge. It's going to be so hard. Yeah, it's going to be hard. I promise it's going to be hard, but it's going to be worth it. So start getting the team together now. The second piece is you got to have the right equipment, right? So to get the right equipment, you've got to figure out what is the current financial model that you're on. So for example, for our institution, if I want to buy something of significant cost, at this point in time, I need to put it in the budget and request it, and I'll get it in July of 25. So that's one of those things that at the bedside or as a CNS you may not be aware of. That's why in those interactions with your directors is so important. So we need to find out what's the cost it's going to be, what's the product that we're going to use, and then how are we going to get it delivered to the bedside. Then with that, once we look at that gets delivered, and then from there, we've got to start to train our teams and create a culture where this is commonplace. One of the things that we want to make sure as we look at this equipment is, what is the nursing burden?
Yes, and good point. And CNS is really great at this. We are great at avoiding costs. So sometimes it's difficult to capture what we do, but if we know how much an AKI costs and what the implications are of that, and we quantify that, we can justify the budget for getting X amount of equipment, or for getting a team or a committee of nurses together to work on things. So great point. And I like let's pick our team here. Other questions? Delia, thoughts on the KDIGO bundle? What are your thoughts?
I like the KDIGO bundle. I think it takes the best elements of Rifle and Aiken and actually makes it more manageable, and it gives you a direction. So I like KDIGO.
Okay, wonderful. Now, a question from Todd. How can we report AKI by stages today, or is that even doable?
You can report AKI by stages by collecting the data. And so as a bedside nurse, you know, one of the things that, and I say this as an old nurse, so those of you who are out there who are in that category with me, remember when we used to look at labs? It turns out not everybody looks at labs anymore. Train our frontline teammates, train our frontline nurses. They are hungry for knowledge. You know, I don't know that you guys know this, but I know this from standing back and watching CNSs over the years. When you come out on the unit and you teach at the bedside, you just share information, you share research, they hang on every single word. Work with your nursing educators to make sure that these folks know how to read laboratory results, interpret them accurately, and then how to communicate that to the provider.
Wonderful. And actually, Tommy, we've shared this as one of the resources. There are some articles and some journals that we will be sharing with you along with some information sheets. But in one of the papers, and kind of going back to your team and tools and equipment, the Accuryn monitoring system, actually there's a paper there and there's a study that shows that it was able to help detect acute kidney injuries 34 hours prior to changes in their serum creatinine. So we recently did another presentation on recognizing early warning signs of clinical deterioration. We look at vital signs, but how cool is that now to have a device that can help you early detect AKI? I don't know that, usually by the time we see it in labs, damage is already done.
Right.
Okay.
And Alice, in addition to that, one of the great things that we like about this, and this is a way to present this to your leadership, Accuryn has also broken the code on something that we all struggle with, which is they have developed active line clearance. So you don't get retrograde flow of urine back up in the Foley because that titling doesn't exist. That passive clearance just never worked. This active line clearance is a game changer for the prevention of UTI, which is something that every hospital is focusing on. That is a never event. We're already there. Someday you may see AKI as a never event. Let's get on the front side of that.
Oh, I love it. Thank you so much, Tom, for this wonderful information. Tom, I appreciate your expertise. Thank you so much. We've put a lot of tools in the chat box. It'll be available also on the NACNS website and in the post wrap-up email. It's been my pleasure to help moderate and ask questions. And right now I'd like to bring back our NACNS representative to help close us out.
So I just want to thank everyone for attending this webinar and thank our presenters for a very informative presentation. We'll be sending out the session recording, slide deck, and the evaluation link for CEs within 1 business day. You will have 90 days to receive CEs if you attended live today or watch the recording. If you have any questions, you can contact info@nacns.org. I also want to remind everyone to save the date for the upcoming 2025 NACNS Annual Conference taking place March 10th to the 13th, 2025 in Boston. Save the date and subscribe to the NACNS mailing list or follow us on social for updates on registration. And again, a special thanks to Accuryn for sponsoring this session and supporting the advancement of clinical knowledge and patient care. Thanks again, everyone.
Thank you.
Thank you.